what I hope to do in the next hour is to try to give us some structure for figuring out when should we invest in diagnostic testing in the shelter, because it's not always a clear-cut answer. And you may not get a clear-cut answer by the end of this, but I hope, again, at least you have some sort of way of thinking about it that might help you arrive to the answer that makes sense for you and your individual scenario. So I always like to think about what the general public thinks of the topics that we're talking about. What is the sentiment out there? What are other veterinarians saying? So I found these 3 news articles or blog posts from various sources online recently. So you see the first one up on the top left. There was this somewhat alarming headline: "Shelter stops testing dogs for heartworm, leaving adopters in the dark." And they went on to say how these local adopters were flawed at the idea that the heartworms were not being tested for in their shelter. They just couldn't believe this wasn't happening. And if you actually read into it and listened to what the shelter representatives had to say, they had some legitimate reasons for why it was not something that they were able to do in that particular time. So you can kind of understand how that can get taken out of proportion. The other 2 I found a little bit more interesting, a little bit more alarming, because they were coming from veterinarians. So here's a blog post over on the left that was written by a veterinarian. I don't know if you guys can see it. It says, "FIV and FELV in shelter cats. When to test or not to test becomes an economic dilemma." And she goes on to describe when you might test and when you might not test in the shelter. And it wasn't quite so inflammatory, but the thing that struck me about that is that it really boiled it all down to an economic question. And certainly that's a factor in deciding when we're going to test and who we're going to test. That's not the only thing. There's lots of other things that we have to consider. And then the last one, which was kind of most upsetting, most alarming to me, and I know it's real small, so I'll read that to you. It says, so this is on a veterinary hospital's webpage. It was written a few years ago, but still up there as a active recommendation. It says, "Shelters do not perform," so they're talking about spay-neuter surgery and what's different between getting your animal spayed and neutered at the Humane Society versus at a private veterinary clinic. It says, "Shelters do not perform preoperative blood work, which can identify undetected pre-existing illnesses. Additionally, pets having surgery at shelters do not undergo a pre-anesthetic physical exam, which is a standard of care." So obviously that's not true. We have a lot of misinformed veterinarians out there. This was interestingly written after the spay-neuter, first edition of the spay-neuter guidelines came out, so really uninformed person out there making recommendations to the public about what we're doing. Really doesn't know what the scenario is. So what I want to do in the next in this session, we're going to review types of diagnostic tests, and we're not going to go into detail about what is PCR and what is serology, what is IFA, all these different things. You guys can look that up easily enough. But what I want to do is present a way that I look at the different levels of testing that we might consider in a shelter, and when we might consider doing those different levels and what are the factors that go into that. Then I'll talk a little bit about the indications for individual animal testing and then population level testing. So, what is surveillance testing and how do we kind of structure a program for surveillance in the shelter? And then the last session, we're going to kind of practice a little bit some of the, I'm going to give you a strategy for figuring out, is diagnostic testing for X disease a good idea for your organization? I'll give you a couple examples, and then we're going to do a little bit of an interactive exercise to try to come up with a testing strategy for a particular disease. So that's the plan, and we'll get to it. So the first thing that I kind of alluded to with the news articles that I put up there is, well, why do we even need to do diagnostic testing in the shelter? We hear, I'm sure you guys hear that frequently, that maybe from some of the folks in your shelters, maybe some of you have said it, we don't need to do diagnostic testing, we can't do diagnostic testing for XYZ reason. You might hear it from private practitioners or other folks, other veterinarians that you interact with. So obviously there's a lot of reasons, and for me it's important that the reasons are linked to an action step. And so some of the key reasons, we want to determine the cause of illness, especially for an individual animal. That could apply to population level things as well. And the action out of that is prescribing the appropriate treatment. Helps us render an accurate prognosis, which is going to be really critical for figuring out that animal's pathway through the shelter system. If we're dealing with an outbreak, we obviously want to know what the cause of that outbreak is, because that is going to direct the management. How long do we have to quarantine animals? When can we release them after they've recovered from illness? What steps do we need to take to mitigate the impact? It's going to be different for every different disease that we have. So it is important to actually figure out definitively what is the specific cause of that outbreak. And then third reason is to identify subclinical animals, right? So we don't know that they're sick, but they could present a risk to other animals in the population. So that's going to inform the biosecurity that we use, the protocols that we have in place. If we're doing any kind of co-housing, that might help inform which animals are okay to put together, which has the minimal risk of transmitting or spreading disease. So there's some generalizations. A couple other things that I think are a little bit more shelter specific. How are we going to allocate resources? We have a finite number of resources in the shelter, and I'm not just talking about money. There's lots of other things that I'll go into in a minute. But that's going to be really critical, if we need to know what we're dealing with. And so diagnostic testing itself is going to be some of those resources we have to allocate, but it's also going to inform the next step of resources, the next group of resources that we're going to use. And then a big one, maximize quality of life. We don't want to forget the animal welfare piece of all this. I'm sure you guys are familiar with the 5 freedoms. And it's actually right in there on number 3. It certainly impacts many of them, if not all of them. But number 3, very specifically, freedom from pain, injury, or disease. And in the ASPCA sheet that they have, it specifically calls out by prevention or rapid diagnosis and treatment. We've got to know what we're dealing with for a variety of reasons, both physical health, both mental health, and for general welfare concerns. So I mentioned types of tests, and I wanted to kind of present those to you. And I break these up into 3 sort of characteristics that I think about the tests and where they fit in each of these categories. And that helps decide, how are we going to deploy these tests throughout the shelter population. So one thing that we have to look at, one bucket, is the resources that are available. How much resources does it take to do X test? Dollars, certainly that's part of it, but what kind of equipment do we need? What kind of space do we need? Do we need special laboratory space to do this? That's something that we need to pay attention to. Knowledge and skill to actually perform the test. Maybe we've got all the supplies and the money that we need, but we don't have the people that can actually do it. There might be legal restrictions in some locations, but it might just be a training and skill thing as well. So we have to take that into consideration, and both for actually performing the test, so collecting samples, preparing them for whatever is going to happen next, sending them out to a lab if that's what we're talking about, and then interpreting the results. And those could be 2 different things. Maybe a trained layperson or a technician can do the collection and performance, but it might require a veterinarian to actually do the interpretation, or it could be that could be translated to trained folks as well. So we have to think about that. And then the last piece for me, the last bucket to consider these categories of tests is feasibility. So we've got, I put a picture of a run full of a bunch of puppies. We've got all these animals looking at us that we have to take care of every day. How much can we actually do this in the shelter environment? Is it practical? Even if we have the resources and the knowledge and skill, do we have the time? Can we make space to actually get it done and get it done in a meaningful way that's going to result in an action step that we need to take? So thinking of those things and how they rank in various tests that we might commonly use, the first category for me that I come up with is what I call core diagnostic tools. And so these are things that I've got the 3 categories here on the bottom: our resources, knowledge and skill, and feasibility. I've colored them all green because there's pretty minimal to no effort needed in each of those categories. Case history. How many of you think of case history as a piece of diagnostic information? See a fair number of hands. Good. So I think we often forget about that. It's an important component. We forget about it probably more in shelters than in private practice or when you're dealing with an individual owner, because you think, well, we don't really know the history on a lot of these animals. They didn't get there by themselves most of the time. So somebody knows something about that animal that we should try to figure out. That it might help us make some decisions for them. So case history, really important. Minimal to no resources required, right? You just have to ask whoever you're interacting with about that animal. Look at any records that might come with it. Physical examination, very similar. So these first 2 are almost in a separate category, because I would argue that these 2 should happen for every single animal that comes in to the shelter. Knowledge and skill required for physical exam. You got to have a little bit of education, but that can easily be trained to non-veterinarians, lay staff, veterinary technicians. Anybody can be taught to do a really good basic physical examination that's going to hit on the really important things that we need to know in the shelter. Again, really critical basic diagnostic tool, requires really minimal effort on our part. The third one is response to treatment. Dr. O'Quinn mentioned this in her last talk as well. And I'm going to do a few slides specifically on this because that's also something we can do that requires comparatively very few resources. But there are some, I don't want to say rules or maybe some guidelines that we should follow when we're going to use response to treatment as a means of actually diagnosing and managing animals in the shelter to make sure that we're doing it in a responsible way. But putting it into these buckets really doesn't require a whole lot. So the next category up is what I'm calling the primary diagnostic tests. So these are your routine ELISA test kits, those SNAP tests that we use. Diagnostic cytology, so things like your skin scrapes, fecal exams, a float or a direct, either one, urinalysis. These are kind of somewhere in between, especially with the resources. You've got to have a little bit of laboratory equipment. You've got to have some test kits available, but generally inexpensive things to maintain and take care of. Pretty easy to train folks to do all of the things on this list here, so it shouldn't be a huge burden to find the knowledge and skill or to create the knowledge and skill to get these things done in most shelters. And they can be performed and interpreted, remember those two pieces of that knowledge and skill, by non-veterinary personnel that are appropriately trained. Feasibility, very high for these as well, really easy to use, take very minimal time, especially if you're talking about like some of the SNAP tests or some of those, the tests that don't require a lot of time to set up and prepare. And you're probably also limiting who you're doing these things on, which plays into that as well. You're probably not going to be doing these across the board. In most cases, you're going to be selecting specific animals, usually with specific clinical signs. So next, we take another level up, and then we have what I'm calling the secondary diagnostic tests. So the other thing that these first three categories I presented to you have in common is that most of them can be done in-house, or at least partially done in-house. So we're not talking about sending things off. That's going to be the next category. So complete blood count, blood chemistry analysis. You might have some of that laboratory equipment, so you can get into a kind of orange zone here. But maybe we're just talking about, take a piece of that. Maybe we're talking about PCV and a total protein and, something that doesn't require as much resources as you might think. So obviously not a complete analysis, but giving us some of that information, some similar information, but making a little bit of a compromise there. Diagnostic imaging. Many shelters have a radiology available to them in some ways, so we're getting into a little bit of a gray zone in this category. Culture. Ringworm culture is probably the most common one here that you might see people doing in-house. How many do ringworm cultures in-house? Yeah, a lot of folks. So we'll see that probably sending out urine cultures and other things. And then necropsy, I think we forget about this as a diagnostic tool as well. So even if you can't do a full necropsy with cultures and histopathology, just doing a gross necropsy can give you a lot of information many times if you're dealing with an animal that died for an unknown cause. So we don't want to forget that and leave it off the list. So equipment and supplies required for these. You might have some level of an in-house laboratory, whether it's really basic with just a centrifuge and a PCV reader, or maybe you have an advanced in-house laboratory with actual hematology analyzers. Non-veterinary personnel can perform most of these things, but I would argue that all of them require a veterinarian to actually result in, to actually do the interpretation of those results. So that's why I've got that category colored as red, sort of the highest level there. And overall feasibility, I'll call that moderate. These things are probably going to all be ordered on the advice of a veterinarian or real specific clinical scenarios that you've set up ahead of time, rather than some of the things on the previous slide. It might be easier for lay persons or you to set up a standard protocol that everybody with X gets a fecal. So this takes a little bit more oversight and management. And then the last category that I would present to you is those things that you're going to probably be sending out to a diagnostic lab. So these are going to take specialized equipment sometimes to collect. You might need to actually order supplies from the laboratory. You're probably going to have a budget to send things out to a diagnostic lab. We're talking about serology here, antibody testing, PCR, and all the variations within there. Culture, for those who are not doing ringworm culture in-house, but culture of wounds, culture of bacterial cases and viruses and that sort of thing. So budget required. People have to be pretty highly trained to know how to collect the appropriate samples, to handle them appropriately. Again, Dr. O'Quinn talked about having the right culture medium can make a huge difference. So we have to know what those things are. And again, a veterinarian is going to be involved in interpreting all of the things on here. So it's sort of another step up. those levels make sense and resonate with you guys? Is that fair categorization of things? Okay. All right, so that's kind of the basic stage to set. So the next thing that I want to look at is, when do we actually do diagnostic testing? And so like I mentioned in the beginning, there's two main goals for it. One is individual animal testing, and one is population level testing. So we're going to look at those separately. When I look at individual animal testing, two main branches come off for me. So one is screening for common diseases, and one is diagnosing existing disease, so individual disease diagnosis. I think I have one quick slide on existing disease diagnosis. You guys know all about that, but I want to spend a little bit of time on screening for diseases. So who are we screening? We're talking about disease screening. It's all members of a defined population. So the population might be everybody that comes into the shelter, but maybe it's just puppies. Maybe it's just adults of a certain age. There's going to be some sort of criteria around who that is, but it's everybody that fits into that group. Generally, these are common diseases that we're screening for, and they're not clinical. If they were clinical, we'd be doing individual disease testing. So why would we want to do this? We want to detect these diseases early so that you can intervene early and then hopefully have an improved prognosis, because you can get on it more quickly. And then the other reason in the shelter that comes up almost all the time is we have to think about the rest of the population. So if we can identify an individual with one of these common diseases that we need to treat early, we can potentially protect the rest of the population if it's something that's transmissible. So a couple sort of practical considerations for thinking about this in the shelter. One is we're talking about things with a long preclinical phase. So they're not likely to develop clinical signs while they're in our care, but we still need to know for the reasons that I mentioned before. Heartworm disease might fit into that. Very common for them not to have any clinical signs, but there may be reasons that you want to know about that. Benefit versus cost. We have to really weigh this carefully in the shelter. So is it important that we treat this disease early? And how do we weigh that with the cost of testing? And let's say we didn't test them and a disease progressed. What are the costs of that? We have to kind of look at those individually for each disease. And then I think if we've decided that we are going to do screening for a particular disease in the shelter, it probably needs to happen on intake, because if you're waiting, then you're kind of losing some of those benefits that we talked about are the reasons that you might want to do it in the first place. So that's one of those things that has to be factored in. If everything else looks good, but there's no way for you to do it on intake, does it still really make sense for you to go ahead with that screening test? It may not. So here's the one slide on individual disease diagnosis. So these are obviously animals with clinical signs. Why? So for the same reasons that we mentioned before, but also add to protect human and animal health and welfare. You want to know what they've got so you can treat them, so you can prevent, if it's zoonotic, prevent people from getting sick, prevent it from spreading. And again, like I mentioned a few times, the results should have an impact on how you're going to treat that animal, how you're going to manage that animal, and or the population. If there's no action that's going to be taken for those results, then you might question why you're actually spending those resources and time to do that. All right, so here's where I want to come back to response to treatment and define that a little bit more. Because it's something that we probably all use, and it's a great tool, and it can be very beneficial, but I think we have to be very strategic about it and just kind of recognize the pros and cons of doing that. And so what I'm talking about here is prescribing a treatment without a confirmed diagnosis. So everybody with signs of URI gets X antibiotic. The key thing here that I think we often forget is that this should be based on two things, at least two things, maybe more, but at least a history of that animal and a physical examination. Doesn't necessarily have to be done by a veterinarian, those two things, but there's some parameters that you've set up that are reliant upon that history. So they fit certain criteria of exposure or clinical signs or whatever it is, and what are you actually seeing on that animal. So those two things should happen before we think of just kind of throwing a treatment at something and seeing if it works. And so how this gets to a talk on diagnostics is we're presuming a diagnosis based on resolution of the problem because of the treatment that we provided. So benefits to that you guys probably all know, because I'm sure everybody makes use of this frequently. Immediately addresses the condition that's there. You can start them on treatment. You don't have to wait for any kind of diagnostics or further evaluation to happen. You can make a decision and get the animal treated. If we're talking about something that's transmissible, we're going to hopefully minimize the transmission of that disease throughout the population. And then I have plus or minus there for reduced costs. So that's really dependent upon did we guess right? So if you made the right guess on that animal and you treated them correctly, you probably got them healthier more quickly, get them out of the shelter more quickly, prevented it from spreading in the shelter. That's going to save you some money. But if you guessed wrong, that's going to prolong the time to that animal getting a resolution to diagnosis and prolong its length of stay in the shelter and all the sequelae that come with that. So what I don't think we consider as frequently are the risks of doing response to treatment as sort of a standard practice. So misdiagnosis, like I mentioned, misuse of pharmaceuticals, Dr. O'Quinn touched on that, particularly with antibiotics and development of resistance. That's a huge concern for shelters, and so we want to be attention to that. Potentially even controlled drugs and other treatments that fall into these categories too. We have to be really careful about that, and so that's definitely a consideration. If we made the guess wrong, so prolonged time to diagnosis, treatment, resolution. Not only does that cost us money and time, that's not great for the animal. That's damaging to their welfare for having to undergo multiple treatments that were not effective, potentially with their own side effects. That delayed its chance of getting out or its time to getting out of the shelter. And then ineffective use of resources. Again, if we got it wrong, we just wasted all that time doing something else. So we want to be really critical about that. So here are some basic guidelines for when response to treatment might be appropriate. One is there's an urgent threat to health or welfare. You've got to do something. You're not likely to, I have another one on the list, you're not likely to harm the animal, but there's likely to be a benefit. You've got to take some action because of whatever the situation is that you have. Maybe you have really severe resource limitations. Everybody automatically thinks they fall into this, but that's why I put severe resource limitations. Like we work with a lot of shelters that there is no veterinarian, like there is nobody to call. So they have to have something set up ahead of time to know when they're going to do these protocols. There's inability to obtain veterinary care. Maybe there's zero budget for that. Maybe it's after hours, there's no emergency plan, something along those lines. There is no other option, then maybe response to treatment is something that you want to have set up ahead of time. Testing, the testing characteristics are really important. So maybe the tests that you have available, they're not very available. It's something you have to send off to a diagnostic lab. Maybe there's not a really accurate test available, and diagnosis is going to rely on layering multiple tests or putting together a clinical and diagnostic picture. Maybe it's just going to take too long. Like if you've got a severe infectious disease problem and you can't wait, a week for some test results to come back, you've got to do something now, then you've got to do something now. And as I mentioned, benefit likely, harm unlikely. So, one example, I was trying to think of examples outside of infectious disease because I know I always kind of fall into that mindset when I'm talking about shelter medical care, but non-medical, this fits for non-medical things too. Maybe you've got an animal that's got an obvious fracture that needs to be addressed in some way. The plan to that might be to actually initiate some sort of treatment. So you're going to initiate pain management rather than waiting for, let's say, radiographs and characterizing the fracture and figuring out what the treatment plan might be. You're going to do something ahead of time. Maybe you've got a huge draining abscess that you're going to want to start it on some type of antibiotic and some pain management before you've actually cultured it and figured out what it is. So the individual scenario is obviously going to differ for each case and for each shelter. And so these are just some kind of general guidelines for when you might want to look at designing response to treatment protocols that are standardized. And so with that in mind, it's really important to emphasize that these should be a standardized protocol under the direction of a veterinarian and built in consultation with the veterinarian, whether or not you have one on your staff or not. The ASV does have a position statement on veterinary supervision in animal shelters, and it talks about having protocols written under the direction of a veterinarian. I think at least 4 important things that should be within that protocol that you create for response to treatment is 1, make sure that patient gets reevaluated after that treatment is started, because we want to know, is it actually working the way that we thought it was, or are we going down that path where we made the wrong decision and now we need to switch gears? You need to know that, so it's not something where you should just start them on this treatment. All right, we'll recheck them when the course is over. They should be started pretty soon, or rechecked pretty soon after that to make sure this does make sense and it's working. Use of first-line antimicrobials, so we always like to reach for Clavamox and your fluoroquinolones, but maybe we should try amoxicillin first, or maybe we should try something that's a little bit more narrow in spectrum before we reach some of the broader spectrum antimicrobial. So really figuring out what that looks like for your shelter based on different clinical scenarios is going to be important. To make sure that you don't get too far down the road of a misdiagnosis when you started one of these protocols, you want to make sure you have defined endpoints. So at what point are you going to say, this probably is not working the way we like to? Now it's time to invest a little bit of diagnostics before we get so far down the road that we've kind of tipped in the other direction and the risks now outweigh the benefits, or the cons now outweigh the benefits. And then it's important that the protocol also address periodic review to evaluate what your standard response is. Let's look at a whole bunch of cases and decide, is our standard response plan, does that make sense? Do we need to tweak it here and there? You want to make sure you go back and figure that out at some point. So the second big bucket for testing is population level testing. So we've got disease surveillance, and then we've got outbreak diagnosis and management. And similarly, I'm not going to talk about outbreak diagnosis and management. There's a whole talk on that tomorrow by Dr. Ditar, and lots of other information out there about that. What I do want to focus on is disease surveillance for a couple of slides. So when we're talking about disease surveillance, what I mean is, this is the definition from the Department of Health and Human Services. They say it's the use of data to monitor health problems to facilitate their prevention or control. And so it really starts, this is an active process. It's active data collection of data of samples for whatever the sample might be, for whatever the disease might be, of an at-risk population. So you have to know what that population is that you've defined. Maybe it's the entire shelter population. Maybe it's a smaller segment of that. But this is a really targeted type of thing based on what the disease is that you're surveilling. That's going to dictate who is at risk. You need to use that information to plan and conduct programs. So how are you going to, is that going to impact the way that you do your biosecurity protocols and your other management protocols, how you treat individual animals in the shelter? That information should inform those things. And then the third part of a true disease surveillance program is looking back on all that and assessing the effectiveness. So similar to what we talked about for response to treatment, looking at that collection of data, in this case it's for one specific disease, and assess the effectiveness of those programs that you put in place. And so maybe you need to make adjustments based on how that's working or not working. So bring it back to the shelter. What does that mean for us in shelter practice? Again, we're looking at common conditions. We want to identify them and document them for the purpose of detecting disease trends. Again, so that we can take a response. We need to know what those trends are. Is disease going up, down, staying the same? And then identify emerging diseases. Again, as Dr. O'Quinn mentioned earlier, or it might have been last night, how the shelters are a great place to find emerging diseases. Many of them are first notified and noticed in the shelter, and so that's a key component of this. So what does that look like in the shelter? I think it happens in a very informal way, very commonly when we do daily rounds or population rounds. We go around and we're looking at the animals and we notice things that are wrong with them. So we're kind of making these mental notes. It's just real informal. And so what I would encourage you to do, or at least think about doing, is having some sort of formal program for specific diseases as well. So one example might be, so you've got two categories there, healthy animals and animals that are clinical. You can do surveillance in both of those groups. Maybe you want to assess your deworming protocols. And so one way to do surveillance for that might be to do fecals on every dog that comes in within a 1-week period, and see what you find, and see if does that actually align with what your standard deworming protocol is, and does it make sense. If it does, great, then you're on the right track. Maybe you find that you're not hitting the most common parasites that you're seeing in the shelter, so you might want to adjust that. Then we're talking about clinical syndromes, and I don't know if this technically qualifies under surveillance. Surveillance is generally healthy animals, but another way that we kind of use this paradigm in the shelter is to look at animals with similar clinical signs. And so a common one is cats with URI. And so we want to know, is it herpes, is it calicivirus, is it something else? So maybe you're going to do swabs from all the cats that have URI at one point in time, and that can help you direct your treatment, management, preventive care protocols. So that's another way that you can use this sort of tactic. So a couple things to consider if you're designing a disease surveillance protocol. How frequently you're going to do this, and that's obviously going to depend on how important is this specific disease that we're talking about. What are the implications for changing management and biosecurity in the facility? Seasonality is going to be important for some of these diseases. The population of shelter is going to change with season, but maybe the disease risk changes outside of population changes themselves, pure numbers of animals that are in the shelter. Location of the animal, so you might do some surveillance based on animals housed in a certain part of the shelter or a certain ward. That might be something that you want to consider. And maybe a certain signalment, maybe just kittens, maybe just puppies, maybe just adults, whatever it might be. Again, this is sort of a disease-based protocol, so you're starting with the disease of interest and then you're breaking it out based on that. So how many animals do we test? If you look in some of the textbooks, they say sort of the mathematical way to do this is if you're looking at healthy animals, you want to ensure a 90% probability of detection. So there's a little chart for how you figure out what that actually means. You have to kind of have an idea of what the infection rate currently is in the shelter, and that'll give you the sort of mathematical answer for how many you have to test to get that probability. Because you want to be able to actually detect that disease so you can gauge how much of a risk is it. If we're talking about clinical animals, what they recommend in human disease outbreak investigations for respiratory NGI is a minimum of 3 to 6 samples. So in most cases, more is going to be better, going to give you more information, but bare minimum is somewhere between 3 and 6. And then the only thing I'm going to say about disease outbreak diagnosis and management is that there are 4 different groups of animals in the shelter that you need to consider if you're thinking about doing diagnostics in an outbreak situation. So you've got animals that are infected or presumed to be infected. You've got those that are exposed and at risk for being infected. You've got those who might have been exposed but not at risk, so maybe a vaccinated animal for a disease that is there's a vaccine available. Then you've got those that are not exposed. So you're probably going to come up with a different strategy for diagnostic testing in each of those 4 groups. So I just wanted to mention that and make sure that you touch on that if you're designing that type of a strategy. So in this last section, I want to give you a little bit of a structure for how you might design a diagnostic testing protocol excuse me, in your shelter, or really it should be whether or not it's figuring out whether or not it's worth your resources to actually do a diagnostic testing protocol for X disease. And so I can't stand up here and tell you should all test for this, this, and this, and not for this, this, and this, because it's going to differ for each of your scenarios. So some very general indications for shelters or whether or not testing should even be on the table for a disease. Some of the similar things that we talked about earlier, but is it something that's really common and you're likely to find it in the shelter? Then maybe we should think about testing and go on to these next steps I'm about to tell you. Is it likely to be acquired or transmitted in the shelter? Is there a risk for spread into the community? Is immediate treatment required to prevent that animal from suffering or to prevent it from getting worse or from being transmitted? Is it life-threatening, or is there a zoonotic risk? These are the things that are going to bump to the top of the list for things that we want to really seriously consider should we take some next steps on. And so there's 4 big categories for me of things to consider and questions to ask ourselves individual to each shelter. We've got shelter operational concerns, testing methodology itself, animal and human health concerns, and some disease characteristics. So shelter operations, you can see some of the questions that I think we should ask ourselves. Are there enough resources available? Will these results actually impact the way that we operate in the shelter? Are we going to have to give up something else because of the cost to do this testing? We want to look at these things. Testing methodology, which tests are even available? How accurate are they? Do we have the ability to collect these samples, handle them, store them appropriately? Knowledge and skill, that piece I mentioned earlier. We want to look at animal and human health concerns. Is it going to affect how we handle that individual animal, how we manage it, how we treat it? What about human health concerns? Do we have to wear a particular PPE? Are there certain people who should be near or not near those individual animals? Disease characteristics, again, is it common? Is it transmission likely? The things that were kind of on that first page there. So we're trying to make a little bit more of a holistic picture. So let me give you a quick example about what this might look like. So here's a example shelter, and we're talking about feline leukemia virus here. So if we look at the shelter operational questions, the municipal animal control facility, they admit 1,000 cats per year. Their outcomes, 500 go to adoption, 300 go to transport, 200 go to euthanasia. They have 1 part-time veterinarian, 2 full-time lay animal care staff, 0 medical budget. And so it's typical, right? It's not an unreasonable scenario. These are based on true shelters. I've altered them slightly, but so think about these questions as you go through. Are there enough resources for diagnostics? There's 0 medical budget, so we're going to have to give up something else if we're going to do this. I didn't tell you the shelter's mission, but diagnosing and managing disease, probably not within the municipal animal control's true function and true mission. So there's going to be some concerns there, some considerations there. Compare that same scenario to Shelter B, private animal welfare organization, 800 cats admitted per year. They adopt every one of them out. They've got 3 veterinary hospitals, 1 mobile clinic, but they have this weird little policy where they are prohibited from adopting FELV positive cats. And so we're going to go through those questions with them, and the answers are going to be a little bit different. And then if we want to throw another wrinkle in it, what if those 2 shelters were not completely independent? What if they were linked together? So let's say they're primary relocation partners for one another. So the first shelter, a large proportion of its animals leave that shelter through transportation, through relocation. The second shelter, a large proportion of its animals are brought in through relocation. So how do you balance those two? Who should be doing the testing, and how do you kind of apply this paradigm to them? It's an interesting question and an interesting thing to figure out. So that's kind of the scenario. So what I'm going to do, we have about 20 minutes, so I'm going to give you a little bit of a disease scenario. Has anybody seen Isle of Dogs? It's a pretty cool movie. You should check it out if you haven't seen it. But the premise behind this movie is there's this disease called snout fever that's an outbreak, and all the dogs have been are presumed to be exposed, and they've all been sent off to live on an island somewhere with their snout fever. So here's background about this particular disease that we're talking about. 75% of all dogs display signs. It's a non-enveloped virus. It's endemic in the state neighboring to you, wherever you might be. You've diagnosed 5 cases in your shelter in the last 3 months, so you know it's kind of creeping in. It's in the area. It's inhaled transmission or direct contact through bites. That's important because let's look at the most common clinical signs are lethargy, fever, hypotension, acute aggression, and what they call spasmodic nasal expiration. Management, basically supportive care. It's a viral disease, but on average takes dogs 14 days to recover from this disease. So that's some background information I'm going to leave up here. What I'm going to do is pass out a number of sheets here that have a little bit of more information for you about a little bit more information about the shelter, the fictitious shelter that you're working in, and it goes through those 4 categories that I mentioned. So shelter operations, animal and human health, testing methodology, and disease characteristics. And Leslie, if you can help me maybe pass some of these out. So there's 5 groups. They can kind of just go wherever. There's, if you guys can just get in groups of like 5 or 6, just kind of nearby you. We'll just pass them around every few. Give you guys one here. And we'll take like 10 minutes or so, maybe 15, to just kind of read the information in your group. Oh, here you go. You guys can push some back there. I can give you more copies. So read through the little bit of background information that I give in for your group and see if you can answer those questions that pertain to each category there. And then we'll spend a few minutes and come back together and decide whether or not we want to test for snout fever in our shelter. So just to kind of rehash, each of your little groups had one of those sections to consider. You didn't have the whole picture. Each had little bits of different information. So let's just do just a general poll. Raise your hand if your group decided you were going to test for snout fever. You are going to test for it in your shelter. Yep. So just a few. Okay. So everybody else was not going to test? Okay. So does anybody in the shelter operations that had that section want to share some of the discussion that went on and what were the reasons for testing or not testing? Sure.
They had it rather than be able to afford the testing.
Okay, great. So yeah, they said in their bubble they didn't have information about how severe the disease was and how many dogs were going to be affected. So it was more information that they wanted to have, but they figured, so you're not testing, right? And you figured that the dogs that were severely affected would have been euthanized in your shelter, so you weren't going to invest resources, which you didn't have. You would have had to take resources away from something else to do that. Okay, cool. Anybody what did you guys that you did test? Which category did you have? Did you have operations or?
Yes,
you did? Okay, so yeah, let's hear from what did you guys think?
So we decided to test because owners are ready.
Okay, so they were going to test some of the high risk intake that are not clinical. Okay.
Does that make sense?
Yeah, yeah. And so part of the reason that I split it up like this, just because it's a giant room, we couldn't have time to do all of them, but also wanted you guys to appreciate that the different considerations that have to go into it. Different people in the shelter might have those bits of information that you need to actually come together and make this decision. So there's a little bit of a method to leaving you in the dark. Somebody else wanted to share? Yeah. Which category did you have?
We had additional information.
Great. Yeah, so this group had the animal and human health analysis, and one of the pieces of information they had was that daily animal care was performed by community service workers who were on a regularly rotating schedule. So that factored heavily into their decision as to whether or not they had the resources to actually do accurate testing. Okay. Yeah. Yeah, great. So this is the testing methodology group, and they I'm not sure which your strategy fits into. There's two different ways to look at it. One is you're just testing the highest risk group, just the ones that have a fever. The other way, it could also be seen as sort of layering the diagnostic tests. That the first test is taking their temperature, and then you're kind of putting together that clinical picture. So both of those, great way to come at it too. So I hope that was interesting and helpful way of looking at things for you guys. I don't need to read the summary for you. It's all the stuff that we talked about. So I hope you enjoyed that. Thanks for your attention, and hope to see a bunch of you back after the break.